There is a very strong imperative in the country, probably an appropriate and laudable imperative to keep people home and in the community as long as possible. This question arises out of the assumption that we may not have things to be generous quite right in the community yet. We're going to ask the panel, we're going to ask Anne and Drew to address this question first, and then we're going to open it up to the audience to both interact with the panel and if you have questions or issues that you think need to be addressed or solutions, to hear those too. So Anne, I'll ask you to go first.
Thank you. I say four things that come to mind most specifically in terms of what we need to address in home and community-based systems of care. First of all, and it's implicit in much of what Howard was actually talking about, is this notion of system integration. We've lived for a long time with home and community care being this sort of poor cousin hanging off the end out of the service continuum, not part of the Canada Health Act with all the kinds of consequences I tried to briefly allude to, and at the level of the lived daily experience of the individual living in their home setting with mild cognitive impairment, a progressing disease. The integration with other systems of care, adult day services, respite care, more support for families. We used, in some provinces like British Columbia in the 1980s, to have much more of a preventive and supportive model of care. So that notion of integration, and he talked about some elements of that, I think are absolutely critical as a way to focus. The second point, which is part of that too, and I thought it was interesting, in one slide that Howard showed, he talked about a training strategy for MDs, nurses, and other clinicians. And I think that's good as far as it goes, but it actually isn't referring to training for the people who are right there on the ground, at the coalface, as it were, of engaging in care for people with increasingly complex needs. So the training of those workers, the recognition that a lot of the work of care is actually done by people who aren't regulated in terms of broad scopes of practice and training. We have to recognize the complex needs that they're dealing with. And certainly in the research that I did in the 3 Canadian provinces, agencies would continually talk about 2 key areas for training needs for these workers, and that would be in dementia care and in end-of-life care. Those are the 2 most pressing concerns. So I would highlight that as a secondary link to integration. A third point quickly, and it's one that I just completely glossed over in my own presentation this morning, is recognizing the ethnocultural diversity of the country in which we live. And in the British Columbia data that I collected, 67% of the workers were people who were from overseas. They were from other countries, primarily the Philippines and China. And we started out looking at what it means in terms of trying to communicate with people in their homes when you don't speak their language. And we quickly became aware that the clients themselves are a very ethnoculturally diverse population. So we certainly had cases of a worker from China and an elder from Iran, and they're trying to learn to communicate in the context of the home in a situation of complex care needs. And so for workers and clients in those contexts, you'll get this clash of health beliefs, health behaviors, capacity to communicate, even differences in cultural practice. If I can just give a quick anecdote, one of the workers that I met whom I personally interviewed, most upset because Worker Compensation Board regulations require that the worker have appropriate footwear where they're in a home setting, particularly where they may be doing a physical transfer of someone from a wheelchair to a bed. So they must wear footwear. And in some cultural contexts, that is entirely inappropriate to wear footwear in the home. This is a really simple example, but it actually was an ongoing source of conflict and agitation in a home setting. So recognizing the special needs for training in the context of ethnocultural diversity is something I think we frequently glide over. And then thinking about the ways we deliver care. I think that's coming back to the model of integration in terms of some issues around cluster care, neighborhood, just not necessarily seeing a single client, a single worker, and just we deliver on that basis, but thinking more collectively, because that could enable us to have a system that's more responsive. People may not be seen as often in their homes setting or as for as long a period of time, but more often and a more rapid response model. So those would be the 4 things I'd emphasize.
Great. Thanks, Anne.
Thanks very much, Carol. I think Anne said it very well, and I'm just glad I'm on such a small panel, because if 4 people had all given their answers, what the heck would be left for me to say? But I think Anne has left me some things I can say at least. Firstly, diagnosis, which is where the process really begins, the recognition that there's a problem and a specific diagnosis. We've done several surveys over the years and found that family doctors often rank their comfort with making a diagnosis of dementia as quite low, and also their comfort at discussing the diagnosis with the patient, not even getting into things like discussing the issue of driving, for example, with them. So we're looking at some educational interventions in a particular rural healthcare setting to try and see if we can pilot some things there that may be able to expand up from there. Home care is vital. Often we get letters from family doctors with something from a home care worker attached, and it's the home care worker who's really recognized that there's a problem and contacted the family doctor about it. I would echo some of the things about multiculturalism that Anne mentioned. When I get patients who don't speak English, it's usually either Cree or Dene that they do speak. And that works okay in their community because other people speak Cree or Dene. But, for example, I have a patient in a rural community who only speaks Polish. Her son is looking after her. He's her only caregiver. And it's very difficult even to put her into respite because no one in the respite speaks Polish. And it's very isolating for this poor woman. Another thing that we're looking at piloting in rural healthcare setting is a navigator for dementia. So often in cancer clinics, there's a cancer navigator who sort of takes people by the hand and gets them to who they need to see. And there's such a plethora of different services run by different aspects of government or private enterprise, and patients and their families often really don't know where to turn. So having a navigator, and that navigator could be a person of many different occupations. It could be someone coming out of home care, could be a nurse. To use an analogy, when we started in telehealth in the early years, the telehealth coordinators, the people who are at the other end when you're doing the call, they were all different sorts of people. Some of them had come to it from nursing. One was a speech pathologist. One was a radio disc jockey. So they come from all different lines of occupation. And I think these navigators can be very different types of people. So I think some order needs to be put onto things, and even maybe having a national dementia strategy. There's an idea, isn't it?
So we have about 20 minutes now for question and answer. And I see there's a mic, Rover, so we'll start here.
Hi, Lisa Ashley, Canadian Nurses Association. So what we're seeing is still in our country 4% of the healthcare budget going towards community-based care, which includes home care. So the ability to spread the types of programs that you're speaking about, which we see have criteria that actually focus on interprofessionalism, abilities to meet the needs of patients and civic engagement, what ideas do you have to help us get that spread and diffusion of those programs across the country? We've worked with the provinces and territories through the Council of Federation and for 3 years, and that model did not work on trying to get them spread.
That is the $64 million question, isn't it? Or $1 billion question. It's interesting. I mean, the Canadian Home Care Association itself has recently called for a recognition of the need for integrated service models. I think sometimes it's sobering to think how far we have to go. If I can just invoke British Columbia for a minute, just last year, the report of the ombudsperson in British Columbia came out, and she was decrying the fact that even within there are 5 health authorities in British Columbia. Even within a single health authority in British Columbia, you will get tremendous diversity in the amount of time. I mean, this is pretty fundamental within a care plan allocated to a particular task such as bathing. So if you can't even get a recognition of a need for consistency from one jurisdiction or one delivery area within a health authority, within a single province. I think that speaks to the challenge of the task at hand. And certainly there's been a lot of discussion, if you're going to have a national dementia strategy, how do you integrate that, for example, with a national caregiver strategy? Linking home care into that, seeing how, despite the fact that home care resides outside the Canada Health Act, how can we get the kind of uniformity that we need? I don't have the answer to that because I think the challenges are so fundamental. I don't know, Drew, if you do.
I don't have the answer either. I think, as was said earlier, we're a nation of pilot projects, and they don't always get translated. Just use an example of our dementia clinic, our rural and remote memory clinic I was talking about. Our health region really didn't know we were doing this. We started it as a research project through the university, and then there was an accreditation visit after we'd been doing this for a few years, and I think it was mentioned by someone, and it was one of the things that the accreditors picked out as being a strong point for Saskatoon Health Region. At that point, the health region started promoting us, putting us in the paper and things like that, say, look, what a good thing. Saskatoon Health Region's rural and remote memory clinic, when it wasn't really theirs. And then when our CIHR funding was over with, we asked them for some money. And they said, no, we're not giving you any money. No. So, and then when we asked the province for money, they even wrote to the province and said, don't give them any money. They already asked us for some. We didn't give it to them. In the end, the province didn't listen to them and did give us some money. But this is the kind of bureaucratic navigation you have to go through to get things to work. Even when you show that it's a good thing and it works, it's very hard to get people to put their money where their mouths are. I don't know if that answers the question, but it's just an anecdote.
If I could just make a quick comment, I was with the Institute of Aging back in the day when that project was funded in Saskatchewan. And I actually think it is worth acknowledging that in my time as scientific director, when we look at the pilot projects that we're funding, this was a rare example of a program where it was research-based, so it was funded by a research agency. And in terms of the comment this morning about what good looks like from Dr. Banerjee, there was an actual recognition in the province of this is what good looked like, and we're going to support that program. It's a rare example of moving from a research program evaluation through ramping up at a provincial level. It's very rare.
Janice Keefe from Nova Scotia Centre on Aging at Mount St. Vincent University. My question has to do with the future over the next decade, and we heard earlier about our success at living longer and the narrowing of the gap of men and women. But a lot of the discussion and the programs that are focused on caregivers tend to be focused on keeping people in the paid labor force. And I just want to highlight that a lot of the care that's provided is provided by elderly spouses of people with dementia. And so I wonder, two questions. How are we going to address our systems of care that will incorporate those individuals who are not as forthcoming to seek out help? And how also will we incorporate the needs of persons themselves with dementia who have a voice to be heard, and yet we have rarely acknowledged that in the work that we've done?
Janice, you probably have as much of a sense of the answers to some of those questions as anyone here. One interesting model that is often promoted as a population ages is the model in Denmark, and I gather they have recently backed off this, but it was actually mandated in Denmark that every person over the age of 80 or 85 in the country had a scheduled home visit every year. So it was actually seen as being important, as preventive in identifying where someone might be living in isolation, might actually be dealing with an increasingly untenable situation with no access to a health system. So the idea was that you actually, once a year in this preventative mode, actually came into the homes of people to do exactly what your question is implying, catch people who would otherwise slip through the system. They've recently backed off the mandating of that visit because they found, in fact, that there were many people who were well, who felt that they didn't want it. They didn't feel that it was necessary. So I'm not aware of what the short-term ramifications of that. I mean, that could be one way of actually of addressing that kind of an issue. Because certainly, even talking to people in the home support sector in British Columbia, they will talk about people who are isolated. Some people with dementia even living on their own and not accessing services, and they'll just have someone in a nearby apartment or home actually identify them in some way. In terms of the notion of voices heard, I think there is much more of a recognition now of personhood in dementia care. There's a center at UBC devoted to this recognition of personhood in dementia, and more initiatives you'll actually see someone with dementia, typically early stages of dementia, of course, being a representative on a committee or a project or something like that. But that remains a challenge in terms of ensuring how we do that, because we heard this morning that there's a quality of life that has to be recognized for people in spite of living with this particular disease.
Yeah, I'd just like to pick up on listening to the voices of people with dementia and their family members. I'm a great believer in that. Every fall we have a meeting of our advisory committee, people from all walks of life from all over the province, some of whom are caregivers for people with dementia, some of whom are people with dementia. And if you Google the Rural Remote Memory Clinic, University of Saskatchewan, you can see some videos where we have caregivers talking about their experience with frontotemporal dementia, with Alzheimer's disease, different things. I think it's important that those voices be heard. Yeah.
Thanks. I think we have time for about 2 questions. So the first one here.
Hi, thank you. Rick Riopel. I'm sharing a table with Dean Mary Dalhousie, and I'm reminded, Drew, of a presentation at last year's Forum on Commercialization of Health Research. And in particular, the presentation by Patrick McGrath from IWK on Strongest Families. And it reminds me to ask you whether in this notion of pilot studies, whether you have approached other jurisdictions or they have approached you with respect to franchising, not-for-profit franchising of what you are doing, which is quite unique in this area, but maps very nicely to what Patrick and his franchise throughout provinces is doing at the other end of the scale with Strongest Families.
Mm-hmm. Kind of like Kentucky Fried Chicken, sort of.
Not for profit. Not for profit,
though. I realize that. No, I didn't hear that last year. I'm not a fellow. I wasn't here last year. I guess that can be fixed, but I'm just kidding. The idea of franchising, I'm not really sure that we need to franchise. I think people can copy the model. I mean, as I said, we've had people from Australia, Scotland, various places come visit and take back some of what we're doing, but adapt it to their own local situation. So exactly what we're doing maybe doesn't quite work in the Hebrides, or maybe it doesn't quite work in the Northern Territory of Australia, and there have to be some adaptations there. So the idea of franchising has never occurred to me before. It's an interesting thought. I'll have to give that more thought. But I think copying what other people do and adapting it to your local situation is very important.
Thanks. Diane?
Yeah, Diane Feingood, Michael Smith Foundation. Kind of for Anne, but maybe for both of you, I want to pick up on the conversation around the country of pilot projects and what levers do research funders like CIHR or Michael Smith have to overcome this problem that you've described, which is we get pilot projects often through the health research funding environment, and then they don't get taken up into the system. And we have also our systems doing pilot projects often without proper evaluation or actually research to actually determine the benefit of it, or without the view that ultimately you might want to scale it up and spread it, and therefore the kind of research that you do actually needs to be a little bit different as well, and plan for that scaling up and spread. So I wonder, in your vast experience, Anne, as a scientific director, or Andrew, in your experience of trying to move something from pilot to scale up, what can we do? What are the levers that I have to pull, for example, in the province of BC?
It's at some level how we have moved in recent years, both in the funding of health research through CIHR, and even I notice increasingly now the Social Sciences and Humanities Research Council will require the quite active engagement of partners right from the beginning of an initiative. And I think in the longer term, but we're talking longer term here, that actually does bode well for the likelihood that you can get at some level the kind of ramping up that we're talking about. But the challenge often is that, again, in the health services context, because those services are delivered at the level of the provinces, there often is a more local feel to those partnerships. And there might be broad organizations, I'll say for the context I work in, the Canadian Home Care Association, that doesn't have teeth in that particular sense. But I think we've started to do it better, as I say, in terms of it, and not just writing to someone after you've designed the project and say, will you come on board, but actually now requiring right from the beginning of the conceptualization of the issue. That could, in the long run, be facilitative of the kind of thing that you're talking about. But it is a fact that research sits here as one way of doing things, and then programming, just like when you got your letter from CIHR saying we cannot now support you in the continuation of the programming. There's no doubt that they are siloed systems.
I don't know what the answer is. Maybe the government needs to sign on from the start. If this project works, we'll support it. I mean, maybe I hear laughter. I'm not surprised, but I think that would be the way to make sure that things continue on if they work. But yeah, it's a tough thing.